Dr. Mahapatra, sir.
Good afternoon, ladies and gentlemen. It's a post-lunch session. I hope that you all would not sleep. I will try my best. Respected chairpersons, my topic today is emerging concepts in myocardial perfusion imaging and molecular imaging. So, coming to the introductions, in the last few decades, numerous technological advances, especially development of new radionuclides, high-resolution gamma scintillation cameras, small gamma cameras, sophisticated small computers have been responsible for improvement in the quality and scope of nuclear cardiology techniques for better identification and measurement of the extent of disease, thereby monitoring the effects of therapy and to better stratify patients in different risk categories. Nuclear cardiology procedures has distinct advantages over other diagnostic imaging modalities, such as having a low radiation risk because a low amount of radioactive are used, being relatively painless and uninvasive, provides both structural and functional information of the organ of interest, superior to other non-invasive tests like routine ECG, stress ECG, 2D echocardiography, MD-CT and MRI study with a sensitivity of 93% and specificity of 95%. So emerging concepts are improvement in the cardiac software program, dedicated small cardiac SPECT gamma camera, new promising molecules, radiopharmaceuticals molecules, useful combined nuclear cardiology techniques. Then coming to the new innovation of cardiac software program, several software packages are available which are designed to process myocardial perfusion data and quantify various important parameters. Quantitative gated SPECT, that is Cedars-Sinai Medical Center software, which quantitated the percent of perfusion defect and all the details. Then 4DM SPECT, then memory cardiac toolbox. Then recently the quantitation of coronary blood flow, which is recently developed by Brigham and Women's Hospital, Harvard Medical School, Boston, and it has been sold to now to 4DM SPECT, which they are going to market, where you can quantitate the coronary blood flow in individual territories. Then parameters, the end diastolic volume, end systolic volume, end systolic wall thickening, all these things you know, left ventricular global ejection fraction, count ratio, transient ischemic LV cavity, heart-lung ratio. Then the last one I want to speak, coronary flow reserve, the stress coronary flow reserve minus rest coronary flow reserve. So coming to that new innovation in cardiac SPECT gamma camera is a dynamic SPECT cardiac gamma camera, DNM530, which has come to the market. It is a solid state dedicated cardiac camera. D-SPECT, another one. Then Discovery, the DNM SPECT, it is interacting multi-pinhole collimators with a solid state modules aiming at slashing the acquisition time without jeopardizing the quality of image. So DNM sensitivity, spatial resolution, energy resolution reveals sensitivity higher, spatial resolution better, energy resolution is improved, count rate is linear on DNM up to 612 kcps as compared to severe dead time limitation to the conventional SPECT gamma camera. So enables the reduction of acquisition time, and first protocols may become a milestone in the evolution of nuclear cardiology as it assumes its key role in molecular imaging of the heart. Enables less quantity administration of radioisotope leading to less radiation exposure. So this is a gamma camera called DNM530. Then another, the system description of the DNM gantry is similar to that of a conventional SPECT gamma camera, but the detector assembly comprises a multi-pinhole collimator block. Each represents a pinhole gamma camera with a very sensitive detector that is called cadmium zinc telluride detectors. So each pinhole detector constitutes a complete miniature gamma camera. So here you can see the image. The first set of the row of image shows in the conventional, and the second one is the B side, the right hand side is the DNM. So there is no absolutely the quality, everything is similar, so one can switch over to the first protocol. Then similarly here also the stress images is acquired only for 2 minutes as compared to the 12 to 13 minutes for stress and rest for 14 minutes in a conventional gamma camera, where you can finish stress at 2 minutes and rest at 4 minutes. So now coming to the D-SPECT, the newly invented non-invasive methods for the assessment of ischemic heart disease in clinical cardiac practice. MPI for evaluating regional myocardial blood flow viability under rest or stress condition has emerged with two clear roles. diagnosis of CAD and assessment of prognosis in patient with known CAD, long-term outcomes for making the most appropriate treatment decisions. Here this is called the D-SPECT, where the patient has to be in the sitting position and the detector, this is the position, and all these things represent miniature gamma camera. So here you can see some shortening of the scan acquisition time, as I have told you, lesser injection of radioisotope, reducing the radiation dose without decreasing the image quality, dedicated solid-state cardiac camera D-SPECT represents an important answer for nuclear myocardial perfusion imaging. Here you can see the conventional SPECT images and the D-SPECT. So you can see almost the images are quite same without jeopardizing the quality. So you can see this. Then the next thing is a new promising radiopharmaceutical, new promising molecules in molecular imaging. Radiopharmaceutical for myocardial perfusion imaging, which you have been seeing, we do by thallium, we do by technetium. Now recently PET perfusion imaging agent which has come, which one is the rubidium-82, then technetium tavoloxamine, then F18 BMS pyridazinone analog, then fluorine-18 pyridazinone, where you can do a stress myocardial perfusion scan. Because usually you must be knowing that F18 FDG is used only for metabolic imaging to find out the viability. But here you can inject as a stress perfusion imaging agent with the PET imaging, PET tracers like fluorine-18 pyridazinone and fluorine-18 BMS. Then radiopharmaceutical myocardial metabolism, BM, fluorine-18 FDG. So these are the glutarate, annexins, and radiopharmaceutical for cardiac sympathetic imaging, iodine-123 MIBG. Then indium labeled fibrinogen for athermatous plaque localization. Then technetium labeled peptides. Then assessment of left ventricular dysynchrony by using high-speed gamma camera with cadmium zinc telluride surgery detector technology. So standard perfusion imaging may underestimate the extent of a disease in a 3-vessel coronary atherosclerosis. So the PET quantification of perfusion reserve, which I was talking to just a second back, CFR, by use of rubidium-82 net retention, defined a greater extent of disease than the standard approach in a patient with 3-vessel disease. Initially, a scout scan is performed by administering a small dose of rubidium-82. Next, attenuation correction by CT. Then the least mode acquisition will start. Then the rest scan is performed, followed by a stress scan. First rest scan, followed by a stress scan. A single injection of rubidium-82, 40 to 60 millicurie injected, followed by emission scanning. Then this delay is important to allow rubidium-82 microextraction from the blood pool and usually 70 to 90 seconds. IV dipyridamole is given as a wet-based infusion over 4 minutes. Imaging started as a least mode acquisition, starting with the time of radiotracer 3 minutes after completion of dipyridamole infusion. Usually 40 to 60 millicurie rubidium-82 is given into the infusion. Here you can see this image that here the myocardial blood flow is almost normal. Global reduction flow is normal, but individual territory which you have calculated is abnormal. So coronary flow reserve is stress flow by rest flow. Normal is more than 2.7. If you can see the third image on the right hand side, coronary flow reserve LAD 1.1, LCX 1.4, RCA 1.1. Here I want to make a point here. Even the blood supply is normal, but that does not mean that the coronary flow will also be normal. So this is the new software which has been come to the market, and people are buying and applying into the study with rubidium. Here another patients of the rubidium study, where you can see coronary flow reserve is all abnormal 1.07, 1.03, 1.16. So this is the new fluorine-18 PET tracers. This is a fluorine-18 FDG analog, requires on-site tracer injection. This has been successfully tried in a rat model of permanent and transient coronary occlusion using small animal PET scanner, as well as recently been tried in human volunteers. Both exercise and rest protocol can be performed as used in combination with exercise and rest perfusion SPECT. During a significant coronary occlusion, this produces a demonstrable perfusion defect which remains unchanged after resting tracer injection. So here you can see a pre-constriction, you can see the normal blood supply, and LAD constriction, you can see a perfusion defect in the anterior wall. And this is the pyridazinone, another radiotracer, PET radiotracer which can be used for stress perfusion imaging agent. Here you can see, you can compare with the thallium and technetium standby. The uptake is very nice and good uptake, and no tracer-related adverse events are noted. Dosimetry is quite acceptable. Stress imaging was feasible with both treadmill and pharmacological intervention. Myocardium was clearly visualized for several hours after rest and stress injection with good myocardial background ratio. 5 minutes gated acquisition and starting 2 minutes after the injection yielded a high quality image. Here you can see the image of the pyridaz fluorinating stress perfusion imaging agent. Here is another patient of the pyridaz. So here you can see the sensitivity is definitely scores over SPECT and specificity also scores over SPECT. And here the some stress score and some rest score and some difference score is quite high in case of PET imaging agent. So now we can combine the nuclear techniques useful, dual isotope technique, new pharmacological agent, modification in pharmacological microperfusion studies. So dual isotope image with thallium and F8 in FDG. So thallium can be injected at 8:30 in the morning, then FDG PET scan at 12 noon, blood sugar level should not be more than 130. The interpretation perfusion absent plus metabolism absent is a match defect called no viability. Then perfusion absent plus metabolism present called a mismatch defect, hibernating viable myocardium. Here you can see there is a perfusion defect in the thallium which shows good metabolism in the FDG PET scan. And here you can see the apical defect in thallium showing metabolism, so there is mismatch pattern in FDG PET. Here you can see the match pattern where there is a perfusion defect in the anterior and apical wall which is persisting in the FDG PET. So it's a match defect, in fact it's scarred myocardium where the patient would not get any benefit out of revascularization procedures. So now with the combined dual tracer used for iodine 130 fatty acids and perfusion tracer system by tetraphosphine. The iodine 120 beam, the decanic acid, fatty acid is the most commonly used branch fatty acid tracer, has a high myocardial extraction and retention with low background activity and low uptake in the liver and lungs 60 minutes after injections. So example,
Dr. Mahapatra, you can conclude faster.
Yeah. 60, I think I'll take 2 minutes time. 65 years old man presented with exertion of chest pain. At time of admission, his chest pain was resolved and a negative serologic and ECG evidence of acute MI. Resting microperfusion SPECT images with technician and tetraphosphine were obtained at the time of hospital admission without pain. 24 hours following the chest pain, iodine 130 beam SPECT imaging was performed with 32 images of 20-second duration. So imaging of ischemic memory. Iodine 130 beam may be used for imaging of ischemic memory in patients presenting with acute chest pain. In subacute phase of MI, suggesting myocardial stunning or delayed recovery of metabolism after recovery of perfusion. In patients with successful revascularization after acute MI, suggest this discordant with iodine 130 beam SPECT uptake reflects a prior severe ischemia after recovery of perfusion or the so-called ischemic memory imaging. So follow-up studies show delayed improvement in wall motion, suggesting they represent stunned myocardium. Here you can see the first set of image with tetraphosphine, there is normal perfusion. Here with the fatty acid imaging, there is a perfusion defect. That is called the past ischemic memory. So new options in pharmacology, you must have heard of adenosine, dobutamine and other things. Here, the regardation things which has come, it has got a no dose calculation thing where you can just put a bolus dose of 400 microgram in 5 ml followed by the tracer, and here there is no calculation of dose weight based calculations, and here you can see the regardation image, stress and rest. And here you can compare adenosine and regardation images. There is a perfusion defect in the lateral wall with resting reversible ischemia, almost it is same. So the take-home message is that regardation is an effective new agent for pulmonary stress, equally effective for MPS for compared with adenosine, reduced side effects and better patient tolerability than adenosine. Single dose bolus injection, alternative dobutamine in asthma and FUD. Since there is no time, I will straight away go to the conclusion slides. Nuclear cardiology procedures are no doubt the state-of-the-art procedures in the present-day clinical practice in diagnosis, prognosis and guidance of therapy in CAD and non-CAD patients. This specialty has grown tremendously for the last 3 decades with the introduction of new imaging agents, modification and innovation of new technology in the instruments, as well as addition of various quantitative softwares with enormous data for last 30 years, has further widened its horizon in the era of multimodality imaging. Procedures are cost-effective as well as promising to the Indian context. Having an increased sensitivity and specificity, all procedures with increasing interest in early detection and stabilization of vulnerable plaque, regression, established atherosclerosis, prevention of heart failure, especially the tagging of the MMP. So all these things, the reversal LB displacement nuclear imaging is moving towards developing newer tools and techniques to facilitate these developments. Detailed overview of all the new methods are discussed in today's presentation. We will have sufficient space for its future growth, especially in a threatening era of multimodality imaging techniques such as CT angio, MR, contrasticography, etc. Thank you.
Thank you very much, Dr. Mahapatra. Please join us here. I think it was a very outstanding presentation on perfusion imaging and molecular imaging. Questions maybe we can ask after the end of all the 4 sessions.